We're proud to launch this journey of clinical excellence with our very first masterclass, Pulmonology. Respiratory medicine sits at the heart of internal medicine practice, where early recognition, structured diagnosis, and evidence-based management save lives every day. This masterclass is designed to equip you with systematic, practical approaches to diagnosing and managing the most common and complex pulmonary conditions you encounter in clinical practice, from chronic disease to acute emergencies, from infectious pathology to complex interstitial disease. This session brings together the full spectrum of respiratory medicine. This is more than a masterclass. It's the beginning of a new standard in internal medicine education. Let's begin.
Wow. Good morning, colleagues. It's a Saturday, and we are so grateful to be with you this morning. I am never alone. I always have backup. And today we have our physician, our coach, our mentor, our brother, Dr. Ryan Swepesat. And it is our first masterclass of the year, and we are looking at everything that has to do with breathing. We are all stations to learn and to become better. Yeah, so this is the clinical care platform. We exist with one mission only, which is to transform the health system one health worker at a time. But can we transform the health system if we ourselves are not transformed? The answer is no. So we are here to make sure that today you leave, this program being better. And yes, there are CPD points, 7 of them, but we are transcending the need for compliance and just focusing on who we need to be so that we can care for our patients and we can also have an awesome livelihood for our families. So yeah, a warm welcome to you. I'm not going to waste a lot of time because we have so much to go through this morning. Let me welcome my brother, Dr. Ryan Swepesat. If you have never met him before, amongst the many skills he has, you are just going to love, and release those good hormones so that your heart, is in a good place. But beyond the jokes and stuff, he is a physician. He is a double diplomat in HIV and internal medicine. But to some of us, a coach, a mentor, but to me, a brother. So we are very thankful to have him on board. Brother Ryan, take us through. Thank you so much.
Wow. Thank you for those warm words, my dear brother Liz.
Thank you.
Good morning, everybody.
Good
God bless
morning.
you. Hope you're good.
We are
Let me
awesome.
share we are great. We are great by God's grace. Yeah. So here's my thing. Let me just maximize it. I was playing around with this toolbar yesterday for diploma, so I moved it. Okay, there we go.
Yep. Let me make you
Yeah. Brother, how's
co-host.
that?
It's perfect. Everything is super. Yeah.
Who's the co-host? Who's the co-host there?
Brother, do check in to check who's in. Carolyn there. Welcome, Aisha.
Oh, yes.
Yes.
100%. Aisha's in the house. Aisha's raising a hand. Aisha, do you have a question? Welcome, Dimitrio and Denise. Ignatius. Ignatius is back again. Hello, Ignatius. We got an iPad in the house. Carolyn, welcome. Linda, Maria, Molebogen, Namshla, Paul, Pete McPherson, Stilindila Dojo, if I'm pronouncing it correctly. And who else do we have? Oh, my screen. Totally Celia. If I've left anybody out, please forgive me. Very warm welcome, Dr. Ntetwa.
Let me see if Aisha needs help. Aisha, your hand is up. Is it the true hand? Is it the high five, or you have a question? If it's a question, do unmute. If it's a high five, do let us know in the chat that no, it's an error. Tulisile, your hand is up as well. Okay, let's hear. Tulisile, you have a question? Going thrice, twice, once. Okay, I think just type in the chat, guys, if there is something, because I see your hands are up. Thanks. Okay, brother.
Okay, brother. Thank you so much. Everybody, I have an important announcement to make before we start. And I've told Brother Mawela, I've been troubled the whole night with gastroenteritis. So I have my rehydrate solution here. So please forgive me if I do need to. I'm not feeling 100%, but we're gonna push and see. By God's grace, we're gonna move on with the masterclass.
Yes.
Um, yes.
You are well,
So
brother.
just a big thank you. Amen. Yes, good morning, Dr. Mtetwa. Yeah, big thank you. First of all, it's good to have an attitude of gratitude. First of all, to my Lord and Savior Jesus Christ for making this possible, and for the CCP. Thank you. Thank you once again for your dedication, your commitment, your enthusiasm, always being there to encourage and motivate and support us and help us to be better clinicians, better physicians. God bless you in abundance. Yeah. So today is we're going to be very long-winded about the short-winded pulmonology, right? We're so excited. This is the first of 10 planned masterclasses looking into different aspects of internal medicine and commonly presenting cases and common pathologies. So the outline of today is to give you a conceptual, systematic overview and approaches that you can put within your clinical acumen and you can flesh out with your patients on a daily basis. So each topic, so I've got 16 key topics in pulmonology to go through. And each one, I've structured it as such. We're going to look through a case study, which may or may not actually have been a real patient. Some are based on real patients I've seen. Some are just patients that I put together, right? And then we're going to go through relevant history and examination per case. Then we'll have a brief look at the pathobiology behind the presenting condition. Have a look at investigations which help us to test for pathology in question. Then we're looking at management as per management guidelines. And certain topics I've also put in little mini quizzes just to consolidate your information at that point. So we're going to go through 16 of these. And then we're going to have a brief look at how to approach investigations in pulmonology. So chest x-rays we've covered on Thursday. For those of you who attended the webinar we had, the quickfire approach to chest x-rays. So yeah, I do have some x-rays, but I don't think we have enough time to go through all the possible pathologies in terms of x-rays. But I'm going to touch on lung function and arterial blood gas analysis. I think these three are key investigations when it comes to respiratory medicine. And I'm really excited about this, brother. It's the master quiz where I'm going to put forth 14 case studies and we can have some volunteers. I know some people are a bit shy, but it'll be nice to hear your voice to come through and to answer some questions based on those 14 quiz scenarios. And thereafter, we're going to go through 41 OSCE questions. So hopefully we can finish within the allotted time. But if we're running out of time, then I will make whatever we don't cover available in the form of a presentation on the platform on the CCP, so you can access the recording of that. All right, is everybody ready? Can you give me a thumbs up, guys, if you're ready to go? You can hear my voice, you can see my slides, and we are good. Hey,
We are good, brother.
Brother Les is playing drums today, yeah? Drummer. Okay, let's go. Conceptual overview. So when I think about the respiratory system, right, I think about different anatomical parts, right, and that helps to facilitate my approach in terms of understanding pathology. So conceptually, the respiratory tract is divided into airway, then lung parenchyma, and then lung vasculature, and then lung pleura. Okay, and then we have the beautiful lung cancer. Lung cancer can affect any of these, so I think it deserves its own little category in the side. Um, so in the airway, the common stuff we see, guys, day to day, asthma. Okay, asthma is relatively common. And those people who have biomass fuel exposure, who are smoking, COPD. Those patients with previous infections, with cystic fibrosis, with issues about, uh, as such, is bronchiectasis, okay, especially in the back of previous TB. And then your foreign body is more of an acute presentation, not that common, and probably won't come to us as physicians, or it'll go to the casualty officer or to the surgeon or somebody else. Um, But in terms of the parenchyma, we talk about pneumonia. Pneumonia is a very big topic, right? So you've got different flavors of pneumonia: community acquired, hospital acquired, ventilator associated, and then pneumonia in the immunocompromised. And that's where we got to think about tuberculosis and PJP and such things, right? Then pulmonary edema, and that we can substratify into being cardiogenic and non-cardiogenic. So cardiogenic is that associated with heart failure. Non-cardiogenic is that associated with acute respiratory distress syndrome, ARDS. We'll have a look at some cases there. Then interstitial lung disease, which can be a standalone feature or can be associated with rheumatology. There's a big link between rheumatology and interstitial lung disease. And of course, pneumoconiosis, your silicosis, asbestosis, coal workers, pneumoconiosis, that kind of thing, right? So all of that fits under the lung parenchyma. Then when you think vasculature, you're thinking, okay, everybody's favorite clot, pulmonary embolism. And then closely associated with that is an approach to pulmonary hypertension, which once again can be primary, standalone, or can be secondary to some other issues. And there's 5 different classes. I mean, look at that. And then pleura, okay, here we talk about pleural effusion, where we evoke Light's criteria, talk about exudate, transudate, pneumothorax, which can be primary or secondary, and mesothelioma, which often is a complication of the pneumoconiosis of asbestosis, right? And then lung cancer, we're going to talk about. And another hot topic that's increasing in prevalence is obstructive sleep apnea. And this is due to a rise in metabolic syndrome, right? Yeah, so this is basically a bird's eye view of what we're going to cover in terms of our cases today. Okay, so important when taking a history in pulmonology, right? Key symptoms you ask on systemic inquiry. Do you have a cough? How long have you had the cough for? Is it productive of sputum? Yes or no? Is it productive of blood? If it's productive of blood, we call it hemoptysis. And then you want to quantify, is it minor or major? So usually major hemoptysis is between 100 to 600 moles for 24 hours. But, patients are not going to quantify it for you. They're going to tell you, very subjectively, I think it's a lot or I think it's a little. So you can probably use a cup and say, okay, do you cough more than a cup or less than a cup, or is it a half a cup or a quarter cup? It helps us to semi-quantify, hemoptysis. It's not a very objective thing, okay? And then coupled to that, we have to inquire about TB. So loss of weight, loss of appetite, night sweats, family contact, okay? That's very, very important in terms of the history taking. And then what shouts out loud in terms of sleep apnea is, do you have daytime somnolence? Very important. When you're working, when you're driving, do you sometimes, feel like you're dozing off? Okay. And at night, do you snore a lot? Do you have episodes where you have repetitive sleep-wake cycles, where you fall asleep and then you snore and then you wake up and then you go back to sleep and you snore and you wake up? That's what we call apnea and hypopnea. And that speaks to obstructive sleep apnea. All right. Smoking is a big thing, right? So, and we know nowadays it's not just smoking cigarettes, it's also vaping, it's also smoking weed, it's also hubbly bubbly. Okay, different kinds of smoking is different kinds of forms. And important to quantify the pack years, which is basically the number of cigarettes you smoke per day divided by 20 times the number of years you are smoking. And that gives us an idea in terms of the chronicity of the smoking. All right. And that's exactly what we have here. Pack years is the number of cigarettes divided by 20 times the number of years. And this is specifically important for COPD. Okay. Any occupational exposures? Okay. Do you work with animals? Are you working with birds? Do you do a lot of panel beating? Do you do a lot of welding or maybe even painting? Okay, where you exposed to fumes? Do you work in the mine? Are you thinking about, occupational exposures? Are you a seamstress? Or do you work with sewing garments? Okay, that's important because that portends, certain pathology. All right. So this is basically a bird's eye view of your signs on respiratory exam. We're going to go through this quickly. So at the bedside, you introduce yourself to the patient, you obtain adequate exposure. If there's a sputum cup, please look at the sputum cup because that will give you an indication if the patient has puddlant sputum production or even blood. Okay. And then what you do is just step back and look for the signs of respiratory distress. So does my patient have tachypnea? So tachypnea means the respiratory rate above 20. Right? Are there recessions, intercostal, sternocostal recessions are the use of the neck muscles, the accessory muscle, the scalene, the trapezius. Okay. Is there audible stridor or audible wheeze? Okay. Does the patient have central cyanosis? So for central cyanosis, obviously you look into the mouth. Peripheral cyanosis, you look at the hands. So by definition, central cyanosis should give you both blue hands and blue tongue. But peripheral cyanosis won't give you the blue tongue. It'll just give you the blue digits. Okay. Deformity, so is there any pictus carinatum, pictus excavatum, previous thoracotomy scar as well is important, right? Okay, so in terms of your vital signs now, okay, you got to check for fever because fever means infection most likely. Check your pulse rate, check for a bounding pulse, check for pulsus paradoxus. So pulsus paradoxus is, okay, a sign which means in the context of respiratory system, severe obstructive airway disease, right? But in the cardiology perspective, it looks at a pericardial effusion, all right? So I don't want to dwell too much on pulsus paradoxus. It's not a very practical sign, but it is a marker of severity of obstructive lung disease, okay? In the hands, nicotine staining, very important. Clubbing, so differential for clubbing is wide, okay? Suppurative lung disease, bronchial cancer, IPF, pulmonary fibrosis, okay? And in terms of suppurative lung disease, we talk about bronchiectasis, we talk about lung abscess, empyema, all right? Then peripheral cyanosis, wasting of the small muscles of the hand is a very useful sign because usually that indicates some kind of brachial plexopathy. And where do we see that? In the context of a superior sulcus tumor. You got a tumor sitting at the lung apex, which then invades the brachial plexus, and that can cause wasting of the intrinsic muscles of the hand. Okay. Wrist tenderness equals HPOA. HPOA is hypertrophic pulmonary osteoarthropathy. It's a periostitis, which is a paraneoplastic manifestation of a lung cancer. Okay, flapping tremor speaks to respiratory failure. But remember, there's a differential for a flapping tremor. So flapping tremor can also be caused by renal failure, by hepatic failure. So by no means does it only indicate respiratory failure, right? And then, of course, you want to look for lymph nodes, okay? Epitrochlear lymph nodes, axillary lymph nodes, cervical lymph nodes, groin lymph nodes, okay? And then you move on to the neck and the face. So trachea, you want to check the position of the trachea, check for tracheal tug. Look at your jugular venous pressure. If it's elevated, that implies some kind of right heart pathology. And usually right heart pathology is secondary to lung pathology, right? You can ask the patient to cough and assess the character of the cough. Is it a very bovine cough, which implies recurrent laryngeal nerve palsy? Is it a high-pitched sound to the voice? Okay, in the eyes, very important, guys. You look for Horner syndrome. So what is Horner syndrome? It is ipsilateral ptosis, meiosis, and anhidrosis, okay? And this is once again a superior sulcus lung tumor which has invaded the cervical sympathetics, right? And that is responsible for causing the constricted pupil, which is meiosis, together with the ptosis, the drooping of the eyelid, and the anhidrosis, okay? Lack of sweating on one side. In the nose, you can do certain things. Okay, so lupus pernio is a classic sign you get on the nose, which speaks to sarcoidosis. Polyps in the nose. Okay, there's a weird triad called Samtis triad, which is basically asthma, which is exacerbated by non-steroidals. And the classic triad is non-steroidal use with wheeze and nasal polyposis. Okay, it's one of those weird things. But just look for nasal polyps, right? In the tongue, you're looking for central cyanosis, right? In the chest, moving to the precordium, you're looking for breast lumps, looking for gynecomastia. And then you go through your entire examination of the chest, right? Inspection, palpation, percussion, auscultation. You guys know, right, how to examine the chest. Important signs you want to check for is for lung, for hyperinflation, right? So you can percuss, and if you have loss of the normal liver downers. So where do you expect to find normal liver downers? In the fifth interspace, mid-clavicular line on the right. But if that area is going to be resonant, then you know that it's usually due to lung hyperinflation, and we call that ptosis of the lungs, and that's often due to COPD. Okay. You have stigmata of pulmonary hypertension. Do not miss that. The loud P2, the palpable P2, the right ventricular heave, the epigastric impulse. Okay, all of that stuff. Okay, Pemberton sign is an important sign where you ask the patient to raise the arms, and after 30 seconds, you're going to see non-pulsatile elevation of the JVP. You're going to see plethora, and the patient may have stridor. And all of that speaks to a thoracic outlet syndrome or a superior vena cava syndrome, often in the context of a apical lung tumor. All right. And then, of course, don't forget to examine the back as well. So you're going to percuss, you're going to auscultate the back, and you're going to listen to the breathing sounds, right? So is it normal vesicular breath sounds? Is there wheeze? Is there crepitations? Is there amphoric breath sounds? Is there bronchial breathing? Okay, there are different signs you can pick up. Bronchial breathing means underlying consolidation. Wheeze equals bronchospasm. Crepitations has a big differential. Okay, crepitations, and I know Italian O'Connor will speak about the timing of inspiration and the character of the creps. So they say if it's early inspiratory creps, it speaks to disease of the airways, most likely bronchitis. And then if it's late inspiratory, it depends on the character. So if it's very coarse character, it's bronchiectasis. If it's medium kind of coarseness, then it's left ventricular failure. If it's fine Velcro-like creps, then it's interstitial lung disease. But I mean, all of this is arbitrary, right? For us, creps is creps, okay? But just bear in mind that not all crepitations is heart failure. Okay, it can be bronchiectasis, it can be interstitial lung disease, it can be bronchitis in the context of a COPD patient. All right. And then abdomen, of course, you check for the liver. If the liver is pushed down, like we said, it could be ptosis. Okay, if it's engorged, it could be cor pulmonale, which is right heart failure. Basically secondary to lung pathology. And in the patient who has right heart failure, you're also expecting to see the raised JVP, the bipedal pitting edema, and so forth. Okay, I know it's quite a busy picture, but it really brings into focus the key signs you want to pick up when you're examining the respiratory system. Okay, a couple of things here. Okay, so if you're percussing the chest, okay, is it hyperresonant? Is there bilateral basal dullness or is it unilateral basal dullness? Okay, so if it's hyperresonant, there's only two things really. And if it's hyperresonant together with bilaterally reduced breath sounds, you're thinking of either emphysema, which is COPD, or asthma. Okay, but if you have ipsilateral absence of breath sounds with tracheal deviation, you may have tracheal deviation. Think about a pneumothorax. Okay, so that's the differential for hyperresonance on percussion. If you've got bilateral basal dullness on percussion, together with a raised JVP and it's stony dull, you're thinking about cardiac failure, right? Cardiac failure will give you a raised JVP. If it is bilaterally stony dull with a normal JVP, you're thinking about an advanced cancer. If you got fine end expiratory creps together with reduced expansion, think about pulmonary fibrosis. Okay. And if you've got unilateral basal dullness, this has a bit of a broader differential. So if it's stony dull, you're thinking about effusion, right? If it's dull and the patient also has a fever, you're thinking, okay, maybe it's an empyema, right? But empyema, usually you have to do a pleural tap when you see the pus coming out macroscopically. And if you're not sure, you test the fluid and the pH is going to be very low. That basically clinches the empyema. Okay, if you got bronchial breathing together with fever, together with unilateral basal dullness, it's lobar pneumonia, most likely community acquired. Okay, and that's where you can also do your increased vocal fremitus, you do your whispering, pityriloquy. Those are all confirmatory clinical signs at the bedside. Okay, if you got clubbing with basal dullness, okay, you're thinking about lobar collapse, phrenic nerve palsy, pleural thickening, or a massive HEPA. Okay, but don't worry, guys. We're going to look at some examples in the context of case studies, putting these signs into perspective. Okay. Now, chest pain. Not all chest pain is myocardial ischemia. Very important. Chest pain does have a differential, right? And this beautiful table kind of really illustrates the key features on history that points to a certain diagnosis, right? So if it's sudden onset chest pain, you're thinking, okay, pulmonary embolus, pneumothorax. And watch out for pulmonary embolus, the patient should have some risk factors for PE. So were they immobile? Do they have recent trauma? Do they have a hypercoagulable state? Okay, I don't want to talk too much about that because we're going to be addressing that when we look at PE specifically. Okay, does the pain radiate to the shoulder or the trapezius? You're thinking about diaphragmatic irritation, right? Often on account of pneumonia or a pneumonic effusion. But of course, a liver abscess can also do that, right? Because liver abscess also impinges on the diaphragm, and that can be referred to the shoulder, right? Fever, you're always thinking about something infective, so pneumonia, pleuritis. Is it associated with dyspnea? Then you consider pulmonary causes, or it could be heart failure, right? Because we know how we grade dyspnea, the New York Heart Association score, or you can even use the MMRC, the Modified Medical Research Council classification. Is the chest pain associated with wheezing? Yeah, then you're thinking obstructive lung disease. Is the chest pain associated with hemoptysis? That's really a red flag for lung cancer. Okay, chest pain with hemoptysis, but it could also indicate a pulmonary embolus, sure, and even pneumonia. Is the chest pain worse with deep inspiration? That's where you think about PE, pericarditis, pleuritis, or pneumonia. Now, is there acute pain after prolonged immobilization? So once again, these are risk factors for the PE. You got to think about PE, right? If the shoulder pain with radiation to the ipsilateral ulnar nerve distribution, it could be a superior sulcus tumor or a Pancoast tumor. It's a little bit about chest pain. Okay, chest pain and key exam findings now. So if you have a decreased systolic blood pressure with inspiration, this is what we call the Passus paradoxus, okay? So let's think through this now. What's the pathophysiology for a Passus paradoxus, right? So when you breathe in, what happens? Your intrathoracic volume increases and intrathoracic pressure decreases, right? So what that does is it pulls blood into the right side of the heart, right? But because of the more negative intrathoracic pressure, there's pooling of blood in the pulmonary circulation. So filling to the left heart is going to be reduced. This is physiological stuff, right? When you breathe in, filling of the right heart is enhanced, but filling to the left heart is reduced because of pooling in the pulmonary circulation. So if you have a patient who has pericardial tamponade, right? What happens when you breathe in? The right side of the heart is supposed to fill, but the heart is enclosed by this uh, pericardial effusion, this ungiving sac in the pericardium, right? So the right heart can't expand very much. So what happens is there's bowing of the septum. The septum bows to the left, and that's going to reduce your left ventricular output. And what does that do to the blood pressure? It's going to drop the blood pressure, right? So that's what the explanation for a Passus paradoxus in the context of pericardial tamponade, right? You breathe in, the right heart has to enlarge very much because of the pericardial effusion. So in order to enlarge, it shifts the septum to the left, reducing left ventricular output, and henceforth you have hypotension on inspiration, right? Which is that. Now, why would COPD give you the same thing? Well, in COPD, there's hyperinflation, right? So when you breathe in, the lung volume is greater than that which you would expect. And because of that, the interthoracic pressure is going to be more negative. And what does that cause? More pooling of blood in the peripheral, in the pulmonary circulation. And this further reduces filling of the left side of the heart. And according to the Frank-Starling law of the heart, the oomph of ventricular contraction depends on the preload. So you're dropping preload to the left side of the heart, reducing your stroke volume, and that has the same effect in terms of reducing your blood pressure on inspiration. And do you guys understand? Can you give me a thumbs up, guys, if you understand the rationale for the Passus paradoxus in the context of pericardial effusion and severe obstructive lung disease? Excellent. So this is really practically not a sign that we often look for, right? Because it's kind of tricky to elicit actually, but it is one of the signs that is in respiratory disease, so it's worth discussing. Okay. If you have asymmetric absent breath sounds, that speaks in terms of pneumothorax or pleural effusion, right? Together with chest pain. And if you have chest pain, which is very resonant on percussion, you're thinking about pneumothorax. And if it's a tension pneumothorax, the trachea will be shifted to the opposite side. Dullness on percussion of the chest wall, you're thinking about pleural effusion, pneumonia. Focal abnormal lung sounds, thinking about pneumonia, and wheeze, you think about asthma, COPD. Okay, so with dyspnea now, so we covered